Hello, this is Rhonda Dickman. I'm a registered nurse and clinical quality improvement specialist with the Tennessee Hospital Association. I help lead THA's efforts to support hospitals in reducing sepsis mortality. In this month's issue of Sepsis Journal Club, we're looking at the article, Organ Dysfunction in Sepsis, an Ominous Trajectory from Infection to Death. This article was published in 2019 in the Yale Journal of Biology and Medicine. It is cited here for your review and is available as a full free text on PubMed. This article provides a comprehensive overview of the features in sepsis patients that lead to multiple organ failure and death. The cornerstone of sepsis-induced organ dysfunction, in the opinion of the authors of this article, is the mismatch between organ perfusion and the tissue metabolic requirements, and that they propose that besides early antibiotic administration and source control, a critical goal in sepsis treatment to reduce mortality is reestablishment of adequate organ perfusion. Their approach to this information is to begin by talking about various aspects of circulatory failure, and then looking at how organ dysfunction occurs in other organ systems of the body and some ways that the magnitude of organ dysfunction can be assessed. So talking first about vascular dysfunction or circuit failure, the authors state that several changes occur simultaneously in the vascular bed of patients with sepsis. There's increased capillary permeability, which is caused by a diffuse endothelial injury and dysfunction caused by pro-inflammatory molecules. There's also decreased vascular smooth muscle response to neurohormonal stimulus. An overproduction of nitric oxide leads to this vascular muscle cell relaxation and prevents patients from responding to vasoconstrictors. They also state that in some septic shock patients, there's found to be a deficiency in vasopressin. With cardiac dysfunction, or what they call pump failure, the authors note that sepsis is associated with acute heart failure, life-threatening arrhythmias, myocardial infarction, and non-ischemic myocardial injury, that these are caused by pro-inflammatory cytokines, which decrease contractility and induce the vascular cell adhesion molecule production. They also state that nitric oxide exacerbates mitochondrial dysfunction, decreasing the myocardial oxygen utilization, perpetuating the release of pro-inflammatory cytokines, and downregulating beta-adrenergic receptors. They also have noted that sepsis impairs myocardial chronotropic response. And looking at the microcirculation, changes there play an important role in organ dysfunction even after hemodynamic restoration. The overexpression of nitric oxide is not homogeneous through all organ beds. This causes shunting and hyperperfusion in some tissues. Sepsis decreases erythrocyte deformability and increases platelet aggregability, forming microthrombi. And nitric oxide inhibits mitochondrial respiration, depleting ATP and causing cellular dysfunction and, of course, organ injury. In looking at indicators of perfusion status, the authors really are about lactate levels. They feel that lactate is commonly used as an indicator of perfusion status, and that clinical signs of perfusion status, such as capillary refill, have really not shown in published literature anyway any statistical benefit over the lactate level itself. They note that patients with hyperlactatemia and no hypotension have a higher death rate than those with hypotension and normal serum lactates. And then in talking about strategies to restore tissue perfusion, the authors state that the mortality rate increases with duration of hypotension. So prompt, personalized fluid management and hemodynamic drug support are needed to hit that goal of a mean arterial pressure greater than or equal to 65. They go on to state that clinicians may wish to implement multiple pressors with different mechanisms of action and then de-escalate as needed based on the patient's response. But doing that approach is a way of avoiding these prolonged periods of hypotension. Moving to the effects of the different organ systems by sepsis, the authors mentioned with lungs that sepsis is the most common cause of ARDS. Alveolar injury and impaired gas exchange, they say, are mediated by pro-inflammatory cytokines, widespread endothelial dysfunction, the platelet activation and microthrombi that form, as well as the formation of neutrophil extracellular traps. And from a strategy or intervention perspective, they just state that lung protective mechanical ventilation strategies are beneficial. In regard to the kidneys, sepsis is the most common cause of acute kidney injury in critically ill patients, and there's multiple contributing factors. Renal hypoperfusion leads to acute tubular necrosis. Ischemia, reperfusion injury, oxidative stress, and tubular apoptosis are factors. The use of nephrotoxic drugs in sepsis treatment have to be considered, as well as the effect of volume overload and the use of normal saline for volume resuscitation, which can lead to very high levels of chloride. In the coagulation system, microthrombi are formed in sepsis. The anticoagulant mechanisms are downregulated by the pro-inflammatory cytokines that are present, which also increase endothelial expression of intercellular adhesion molecules. The endothelial production of thrombomodulin is severely impaired, and the neutrophil extracellular traps induce platelet aggregation, thrombin production, and fibrin clot formation. These lead to the depletion of platelets and coagulation factors, which then leads to thrombocytopenia and DIC. In the liver, the response to pro-inflammatory cytokines causes hepatocytes to release acute phase proteins that have widespread pro- and anti-inflammatory effects. The authors go on to state that the hepatocytes may play a pivotal role in balancing the immune response in sepsis. Liver injury can occur a couple of different ways. One is hypoxic hepatitis, which is caused by profound hemodynamic alterations, microthrombi and sinusoidal obstruction, and endothelial dysfunction. Liver injury may also occur from sepsis-induced cholestasis, either from impaired bile formation and or defective bile flow. Pro-inflammatory cytokines alter hepatocyte expression of bile acid transporters, and they also, along with nitric oxide, lead to ductular cholestasis by inhibiting cholangiocyte secretion. Within the central nervous system, sepsis can cause encephalopathy. This is brought about through hemodynamic instability, which is worsened by the autonomic dysfunction that can occur if the brainstem is impacted. It can also be caused by sepsis-associated cardiac arrhythmias, coagulopathy that causes either ischemic or hemorrhagic stroke, inflammatory response-related microcirculatory failure. In fact, this can affect the blood-brain barrier, and there can be an influx of inflammatory mediators and neurotoxins into brain tissue. It can also be brought about by oxidative stress from nitric oxide diffusion across the blood-brain barrier, or the disruption of cholinergic and dopaminergic neurotransmission. In looking at how clinicians can estimate the magnitude of organ failure, the authors mention several tests. The first is the SOFA score, the sequential organ failure assessment, which they state has good mortality prediction value, but requires tests and resources that may not be readily available outside of the ICU. So they mentioned 3 bedside assessment tools that can be done outside of the ICU that are done with typical bedside exam. One is the Modified Early Warning Score, or MUSE, the National Early Warning Score, or NEWS, and then the Quick SOFA, or Q-SOFA, which they state performs worse than MUSE and NEWS. They really recommend any of these as tools to help the clinician. In conclusion, the authors state that sepsis is highly complex and lethal, with a convoluted pathway from infection to death. Each organ injury contributes to the patient's risk of death. Interventions beyond supportive measures and infection control have failed to improve outcomes. A personalized approach to treatment is needed. And then just to add a few personal comments as I reflect on this article. One, it certainly demonstrates the importance of restoring tissue perfusion as promptly as possible. And the authors did not mention, but I think it sheds light on the importance of careful management of underlying chronic health conditions that could also alter perfusion. Lastly, I think it stresses the importance of education campaigns, both for the general public and frontline healthcare professionals, to optimize early recognition and treatment of sepsis and intervene before we begin seeing these later pathologies that lead to organ failure and death. It's an interesting article, again, available as a free article on PubMed. Thank you.